Hello, everyone, and welcome. Welcome to Heart Failure Grand Rounds. I think we can safely call it that now. Today we are in for a real treat. We are joined today by one of our advanced heart failure colleagues, Dr. Jeffrey Testani. Dr. Testani is a heart failure transplant cardiologist. He's also a very accomplished researcher. He does carry NIH grant funding, and he has focused his very impressive research career on trying to understand the cardio-renal interactions that occur in heart failure. And we look forward to his discussion today on that area. I could go on for quite a bit, but I think I'll cede the floor to Dr. Testani. Jeff, thank you very much for joining us. We are thrilled. We have a huge audience, and we look forward to learning from you today. Thank you very much.
All right. Well, I look forward to disappointing after that introduction, but thank you so much for having me. All right. So everybody can see my slides, hopefully. Yeah, so today I'm going to talk about cardiorenal syndrome and diuretic resistance. Here are my disclosures. All right, so what is cardiorenal syndrome and what does it have to do with diuretic resistance? If you type in cardiorenal syndrome into PubMed, there is quite a bit that comes up. A lot of review articles, most of them have pictures like this. I can kind of distill this literature down for you. Picture of a heart, picture of a kidney, arrow going back and forth with bad stuff listed in that arrow. And just about anything you can think of has been implicated in driving cardiorenal syndrome. So there's a lot of hand waving. Really, there's almost as many review articles as there is actual original research in this topic. So why is there so much hand waving? Why are there so many review articles written? Well, turns out renal dysfunction is incredibly common in heart failure. So this is from the ADHERE registry. It's often very similar in different studies. And really the majority, particularly of our admitted heart failure patients, have significant, stage 3 or greater chronic kidney disease. And it's actually relatively uncommon to be admitted to the hospital with a normal GFR. In addition to the fact that it's common, over the last 20 years or so, we've accumulated this huge literature showing both baseline renal dysfunction and a worsening in kidney function, at least in all comers, seems to be associated with worse outcomes. And in addition to the fact that, it's associated, this really isn't one of these wimpy epidemiologic associations. Renal function is reproducibly one of the most powerful predictors of mortality. This is from one of the earlier studies kind of illustrating you'd actually rather have a worse ejection fraction than worse renal function from a prognostic standpoint if you were a heart failure patient. This is one of my favorite papers from Greg Fonerow, where they took all the variables in the ADHERE registry and just basically told a computer to pick the prognostically most important variable. So completely agnostic to any hypothesis, just machine driven. And they found 3 variables that predicted most of the in-hospital mortality. BUN and creatinine were 2, with blood pressure being the 3rd. So really important prognostically is renal function in heart failure. So there's a lot out there, hand waving on mechanisms and inflammation and oxidative stress and this and that. But I think of cardiorenal syndrome a lot more simplistically. Basically, kidneys behaving as if there's volume depletion when no depletion is present. And clinically, this shapes up as a reduced GFR or an elevated creatinine and increased sodium avidity or diuretic resistance. So what I want to do here today is kind of cover the highlights of what we've learned over the last 20 years or so of cardiorenal research. A lot of this is what we thought we knew was wrong. Then turn to the sodium avidity and diuretic resistance side of things. All right, so what do we know about mechanism? So the way I was taught in medical school to think of cardiorenal syndrome, it's low cardiac output causes reduced renal perfusion, ultimately leading to renal dysfunction. I think a lot of us were taught to think of it this way, this kind of low forward flow hypothesis of cardiorenal syndrome. So what has the contemporary literature taught us about this? Well, no one's actually ever been able to show this in a contemporary heart failure population. This is so ingrained into the way we think of cardiorenal syndrome. I want to show you some of the raw data here. Because this just doesn't seem to be the factor that's driving things on a population level. So this is a whole bunch of cardiac indices plotted against eGFRs, and of course, as you can see, you can have a normal GFR with terrible kidney function, but importantly, you can have a totally normal GFR in the setting of really pretty overt cardiogenic shock. This is from a different paper we published to look at this, where BUN to creatinine ratio, we normally think of that as this really pre-renal metric. If anything should be influenced by quote unquote low forward flow, it should be BUN to creatinine ratio. But here in the ESCAPE trial, if you're in the top tertile or bottom tertile of cardiac index, same exact BUN to creatinine ratio. This is from a paper we published to try to drive this point home. So we looked at people with either worsening or improvement in kidney function. So coming to the hospital and their kidney function goes in opposite directions. When you look at cardiac index at baseline, cardiac index at the time the swan is pulled, and the change in cardiac index, again, no different in people that either worsen or improve their kidney function. So if it's not forward flow, then what is it? Well, for quite some time, we've been talking about backwards failure or congestive nephropathy as a contributor to cardiorenal interactions. And there's actually a pretty robust animal literature to say that this happens. So this is from a rat kidney preparation, and basically as you increase the pressure in the kidney, we see sodium excretion, renal blood flow, GFR, all will precipitously drop as the pressure in the renal veins increased. As soon as you normalize the pressure in the renal vein, kidney function returns back to normal. So does this apply to humans with heart failure? We think it does. Most human research to date has focused on CVP. And there's probably about 10 papers or so that have looked at CVP and various metrics of renal function. And by and large, there's no signal that emerges. Some show a positive association, some a negative association, not really much. So we can spend a long time on this, but I think there's a lot of reasons that this CVP literature hasn't borne out much. Some of this is because of the fact the kidney's in the abdomen, not in the chest, where we measure CVP. And particularly in our obese US population, we can see pretty big discrepancy between intrarenal pressure or renal vein pressure and central venous pressure because of obesity and effects on the abdominal compartment. And importantly, congestion of the heart, I mean, we know this has positive effects on renal function, right? You stretch the atria or the ventricle, you get natriuretic peptide reduction in renal sympathetic tone, so on and so forth. So congestion overall of the heart should be good, even if congestion of the kidney is bad. So I would say the most compelling human data on congestive nephropathy is looking at intra-abdominal pressure. And this is a great paper from Wilfred Mullins showing with relatively modest increases in intra-abdominal pressure. And you can measure this sort of fully if you're so inclined. You see kidney functions worse, the higher intra-abdominal pressure. And as you lower that intra-abdominal pressure, kidney function seems to significantly improve. So what do these changes in renal function mean as far as prognosis? So I showed you, at least in all comers, worsening renal function seems to be pretty bad for people. But this is concerning, right? Because we do this to our patients a lot. We start our ACE inhibitor, SGLT2 inhibitor, Entresto, the creatinine bumps. Are we hurting people when we do this? So let's start with improvement in renal function with diuresis. So somebody comes in, they're too wet, they have congestive nephropathy, you diurese them, kidney improves. So that's got to be a good thing, right? Improvement in creatinine, got to be good. So when we've looked at this, and there's probably 6 or 7 papers at this point that have looked at this, improvement in renal function is oftentimes just as bad as worsening renal function. So this is from the ESCAPE trial, this is from the DOSE trial, where people were really aggressively diuresed. Worsening renal function was statistically significantly better for you than improvement in renal function. So what if we keep diuresing people all the way back down to bad kidney function? So they come in, they improve, we keep diuresing, they end up with worsening renal function again. So it turns out this is not uncommon. So maybe 40% of people that have improvement in renal function at some point will no longer have that at discharge. And if you look at these people with persistent versus transient improvement in renal function, so similar peak improvement in GFR, but the guys with transient improvement in renal function go home with kidney function about as bad as they started. When you drill down a little bit more, the people with transient improvement in renal function, significantly longer length of stay, significantly greater volume loss, trend towards more diuretics. So it really seems like the doc kept him in house to diurese him for another couple of days. So you think this would be bad, right? Well, it turns out the people that were kept in house for another couple of days, got more diuretics, were diuresed into bad kidney function, actually have significantly improved survival compared to those discharged with improved renal function. So does this mean good kidney function is bad for our patients? Of course it does not. It just goes to show you that when we're looking at these changes in kidney function, they're really just surrogates for what's going on. And the bottom line is you want to treat the heart failure, make the heart failure better, and these small transient changes in kidney function are pretty much irrelevant. And that's, I think, the one clear message that has emerged from the literature over the last 20 years is if you're doing something that's the right thing for your patient, within reason, a bump in creatinine is really doesn't mean anything, and take care of your patient. So this is worsening renal function after starting an ACE inhibitor. If anything, that's a good thing. Same thing with spironolactone. Worsening renal function is setting hemoconcentration. Hemoconcentration, a surrogate for reduction of blood volume. No prognostic significance there. Worsening renal function if there's no longer a sign of congestion. So, you kept the IV Lasix going for an extra day more than you needed to, the creatinine bumps, that doesn't seem to matter. You're titrating the vasodilators and the blood pressure comes down, creatinine goes up. This doesn't seem to matter. So why is it this treatment-induced AKI is not bad? The nephrologists have really made a big point of naming this acute kidney injury. There's injury going on. It's really bad. But we don't actually have any evidence that there's injury occurring in these heart failure patients undergoing diuresis. And we and others have looked at this recently to try to nail this down. Is there actual injury going on? And so we looked at it in the ROSE trial, which I think was like the perfect place to look at it. So ROSE was a negative trial of dopamine and Niseratide versus placebo. But the reason it was a great trial to look at this in is they got really aggressive diuretics. So everybody got the high dose arm of the dose trial, basically. And we know in the dose trial that more than doubled your rate of getting worsening renal function. So we know that this dose of diuretic is enough to cause iatrogenic bumps in creatinine. As you'd expect, people peed like crazy. Placebo group made over 8 liters of urine because they're getting a lot of loop diuretic. And so we measured tubular injury biomarkers at baseline in 72 hours to see what was going on. And so for those of you who are familiar with these markers, NGAL, NAG, KIM1, these are kind of like the equivalent of the troponin of the kidney. So in the same way troponin shows you is there actual myocyte injury, NGAL, NAG, KIM1, they say is there actual injury to renal tubular cells. So not just a hemodynamic functional change, but is there true injury or a tubular necrosis? And as you might expect, we didn't find any evidence of that. So if you bump your creatinine versus not, changes and levels of biomarkers of tubular injury are exactly the same. So importantly, these are pretty small changes in kidney function. So as cardiologists, we're actually pretty good at not doubling the creatinine very commonly. So even with this very aggressive background diuresis, we're pretty small. Most people are having 0.3, 0.5 at the very most bumps in creatinine. So big changes in creatinine are small, but reassuring here. And again, these are very small numbers. Even in the people in the top decile here that had bigger bumps in creatinine, there wasn't any signal that there was this threshold effect where, if you bump the creatinine a certain amount, that it bumps. But again, very small numbers there, but reassuring. So this has been shown several times now. Probably the biggest trial that's shown this is akinesis. This was sponsored by Abbott and their platform to evaluate NGAL. They were hoping this was going to get a lot of NGAL kits sold for heart failure patients, but as you can see here, urine NGAL basically had no value whatsoever in these heart failure patients, really because tubular injury is not probably a relevant physiology in acute heart failure. So little disclaimer here, does this mean that we can ignore the creatinine? So a lot of us interpreted this to say, creatinine just doesn't matter, we do whatever we want. So we don't really know that. So we know that it's probably fine if we accidentally bump the creatinine a little bit when we're shooting for no change. If we all of a sudden say, we should shoot for a 0.3 bump, then we really don't know what will happen. And Zach Cox did a nice job to illustrate this. This is what we've been doing when all this data was generated. So we're trying for no change. And in 20–30% of the population, we get this 0.3, 0.5 bump. And this is perfectly safe. Like this is really well established now. But if all of a sudden we say, okay, it's totally fine to go to a 0.3 bump, then when we overshoot in our 20–30% of the population, we're going to end up with pretty big changes in renal function. And so we don't really know that these more extreme bumps in creatinine are going to be associated with real tubular necrosis, permanent renal injury, or worsened outcomes. So the reality is we just really don't know, and you know, more clever therapy rather than just permissive hypercreatinemia is probably the way to go. So conclusion from data thus far: if the creatinine moves a little in the process of getting people on life-saving meds and fully decongested, this appears to be okay. So if we shouldn't focus on the creatinine, then what is the pathophysiologic lesion we should be focusing on? And to a heart failure audience, we don't need to convince you that this is probably congestion, you know, on a population level. People coming into the hospital for heart failure are by and large coming in for congestion, with low flow being a pretty uncommon presentation. And, you know, we've certainly grown to appreciate over the last decade or so that congestion is probably more than just a cause of symptoms. Congestion probably does a lot of bad things and sets up a vicious cycle of worsening heart failure and organ damage. And you know, the prognostic literature has really borne this out as well. So this is from the guys at Duke saying what's more important, fluid versus flow, and at least in the ESCAPE trial, you'd rather be discharged with a cardiac index less than 2 than discharged with a wedge pressure greater than 20. So volume overload is bad, so we should just give people a little bit of Lasix, dry them out, and all our patients will live forever, right? Well, of course, us as physicians in general, we are not particularly good at doing that. So this is from the HERE registry. This is dated data, but you know, it's really the best we have. And honestly, I don't think much has changed, but at least, you know, back in 2003, even though most folks were in the hospital to lose fluid, 53% lose less than 5 pounds, and actually 20% of people in the ADHERE registry lost nothing or gained weight. So not great. So this is clearly multifactorial on why this is happening, but one of the reasons is probably diuretic resistance. So it turns out on a population level, some degree of diuretic resistance is probably essentially ubiquitous. Diuretic refractoriness is fortunately quite rare, but resistance is normal in a heart failure population. So normally, if you give a normal person 40 milligrams of Lasix, they're going to make like 3 liters, maybe 4 liters of urine. In the setting of heart failure, we're talking about 300 or 400 cc's of urine on average to 40 milligrams of Lasix. So a lot less diuretic response on a population level in heart failure. So it turns out most of this diuretic resistance is relative, and we can overcome it with aggressive titration of loop diuretics. And it turns out the dose response curve for loop diuretics helps to make this a pretty safe endeavor. So I want to spend a little bit of time on the dose response curve. I know you've all seen this, but this is the dose response curve. You can measure how much salt is coming out of the nephron by looking at the FeNA. This is how much Lasix is required to elicit that response. We have the threshold, the steep portion, and the ceiling. And so I'll spend a minute on each of those. All right, so the threshold this is really your main enemy when you're taking care of heart failure patients. So if you're below the renal threshold, you don't get any diuresis. If you give them the same dose 8 hours later, again, 0 diuresis. You have to get over this threshold to really get the patient peeing. Unfortunately, this is really hard to predict. It has, you know, in CKD and other settings, it's pretty heavily based on the GFR. But in heart failure, the GFR tells you very little about how well they're going to respond to their Lasix. And so really the only way to figure this out is through trial and error to get to a high enough dose that gets you over the threshold. So once you're over the threshold, you're on the steep portion. So I'll draw your attention over here to the response element, 2, 4, 6, 8, 10, 12, nice linear increase. And the amount of diuretic to elicit that, 0.01, 0.1, 10, 100. So this is a log linear relationship. So what does this mean? You need a lot more drug to get a little bit more diuresis. So here's some trial evidence to support that physiology is relevant in our patients. So the dose trial, which I'm sure you're all familiar with, high versus low dose Lasix. So high dose group got 2.5 times the dose of diuretic of the low dose group. We see 4.9 versus 3.6 liters of net urine output. So that turns into a 36% greater urine output with, you know, 2.5 times the diuretic dose. This is a study we did at Yale that we haven't published yet. Similar thing, we gave a single dose, 2.5x the dose they got the day before, and basically 370 mils of additional urine output the patients made when you gave them 2.5 times the next day. So a lot more diuretic for a little bit more pee. Then last we have the renal ceiling. So the renal ceiling is the drug level where every sodium potassium 2-chloride co-transporter, or the target for loop diuretics, is saturated. So if you take a normal person, you get them 40 of Lasix, then you give them 80 of Lasix, you give them a gram of Lasix, and you measure how much salt is coming out of them per minute, they will not pee any faster to a gram of Lasix than 40 of Lasix. So they'll pee longer to a gram of Lasix because there's more drug in them that has to get cleared, but you can't make them pee any faster. And as we're learning more about this, in our diuretic resistant patients, it's really like a lot of diuretic required to actually get up over here, if it's even possible. Lastly, and importantly, the majority of diuresis happens in the first few hours after you give a dose. In a normal person, if they're going to respond, they pretty much stop peeing by 2 hours. So that can be extended in the setting of volume overload, but the point is that the response is early if it's going to happen. And so there's some practical implications here for diuretic dosing. First, major goal is to find the dose that gets them over the renal threshold and on the steep part of the curve. So when interns ask me how much diuretic to give, I say, if you don't know what dose to use, start with 80. If you have a number in mind, double it and give that. Once you're on the steep part, it takes large changes in dose to produce modest changes in diuresis. The whole notion, I see this all the time, the house staff go from 100 of Lasix to 120. And that really just doesn't make any pharmacologic sense. Like it's a log linear relationship. So you really need meaningful changes in diuretic if you're trying to get meaningful changes in response. Even if you really blow it and give them way more diuretic than they need, the renal ceiling is going to protect the patient. They'll only diurese longer, not faster. So basically for each doubling of the dose, you're going to get 1 additional half-life of the drug. For Bumex and furosemide, we're talking 1 to 2 hour half-lives. So an average patient with moderate diuretic resistance and renal dysfunction, we're talking about 500 to 750 cc's of additional urine output, even if you give them 2 or 4 times as much diuretic as they need. So the point here is that it's pretty easy to hurt people with systematically underdosing them and taking days to find a therapeutic diuretic dose when they're the sickest, the most congested after coming in for heart failure hospitalization. But the flip side is it's really actually pretty hard to hurt people with 1 or 2 doses of even way too much diuretic. So if you're going to err on either side, the safer is likely to give them a big slug of diuretic and back off if you need to. Lastly, it makes no sense to wait until the next day to titrate diuretics. Majority of diuresis happens in the first 2 to 3 hours. Even in heart failure patients that are volume overloaded, more than 50% of the urine output that they're going to make to that dose will come out in the first 2 hours. So really, titration of diuretics should happen more frequently than once a day, which is how it's done in most hospitals. So we've been trying to leverage this physiology at Yale, and we created this nurse-driven diuretic titration pathway, and it's basically the same thing as a nurse-driven heparin or sliding scale insulin protocol, but rather than giving heparin based on a PTT, the nurse is giving Bumex based on sodium output. And I would submit that diuretics are way safer than heparin or insulin, which are actually pretty dangerous drugs, but we leave that to the nurses confidently all the time. So the first problem we need is something better than fluid output and daily weights. So daily weights, if we're lucky at Yale, we get them every other day, oftentimes not at all. So you can't obviously titrate diuretics rapidly with that. And doing net fluid output is pretty tricky, as I think everybody can relate to here. This is an example I like to show of a patient took care a while ago. So we came on service, he wasn't making much progress, switched around all his diuretics, made 7.5 liters of urine. A lot of high-fiving and rejoicing about how smart we were. 10 days or whatever later, he was 50 liters of urine he had produced. But when we look at his weight, he went from 79.5 to 77. So obviously we weren't getting everything there. According to Epic, after 3 months of being in the hospital, he was 441 liters negative, which would have made him, negative 200 kilos or whatever. So obviously we were missing some of the fluid intake, which is pretty easy to do. So measuring sodium output is probably better. So sodium is actually the pathophysiology of interest. So the fluid just follows the sodium. It's actually the sodium that is driving the volume overload. But importantly, and probably more importantly, that there's a lot less variability in sodium intake. So, that guy I showed you, he was clearly getting to the sink and filling up his water pitcher as much as he wanted to. But they usually don't have ad lib access to salt. So the variability in salt intake is going to be a lot less than the variability in water intake. So this is borne out in prognostic data. So turns out even if you have a net negative fluid loss, if you have a positive sodium balance, you do much worse than if you have a negative sodium balance, which makes sense with the physiology. So can we predict sodium output? Yes, we can do that pretty well in the same way we don't do 24-hour urines to measure GFR anymore. We just get a spot urine or a spot plasma creatinine. We can do the same thing with diuretic dosing. So you get a spot urine, sodium, and creatinine, and you put it into a formula, much like a GFR formula, and we get pretty good prediction. So this is the clinical kind of nursing-driven ins and outs here compared to gold standard measured sodium output. Turns out it's pretty crummy, as I think to predict poor diuretic response. We have AUC at 0.7, not very good. If we use an equation, we get AUCs that are really pretty good over 0.9, definitely clinically actionable. So if you do want to use this equation, order a spot urine creatinine to sodium. Works the best if you get about 2 hours after the diuretic is given. We have an online calculator, cardiorenalresearch.net. Basically plug and chug with the variables, and it'll tell you how much salt and water is going to come out of your patient. So this allowed us to create and operationalize the diuretic pathway at Yale. It's really a diuretic protocol, but at Yale, if you call something a protocol, there's like tons of paperwork. So we call it a pathway, and we were able to get it online. So basically, clinician orders the pathway in Epic, which is one of these standard Epic order sets. You specify or just accept the defaults on starting dose of diuretic, goal output for the day, stopping parameters like how much the creatinine and blood pressure can change. And the nurse takes it from there. Pretty much every 6 hours, they titrate the diuretic based on the equation-based sodium output. So we published this not too long ago, the first 161 patients, and we looked at the 3 days before and the 3 days after the pathway was initiated. This wasn't a randomized trial. It's just something we put in clinical practice. And so as you'd expect, so before they got the pathway started, diuretic dose was stable, urine output was stable, weight was not going down. We start the pathway titrates up the diuretic very rapidly, urine output goes up, and the weight starts to come down. So it works. You give people more diuretic, they tend to pee more. Overall, this appeared to be safe, surprisingly safe, to be honest. Big changes in creatinine were not particularly common. The only thing we really saw was an increase in potassium supplementation. There's also a sliding scale potassium that comes in the order set. So a lot of this is really probably just driven by the fact that they're getting more potassium or they have access to more potassium orders. But severe hypokalemia was not an issue. So what do we do when titrating the loop diuretic isn't enough? Short answer, no one really knows. And we certainly have a lot of novel therapies in the clinical trial graveyard. You'll probably all remember for a while there, it was like every 6 months, there was one of these big high profile negative New England Journal of Medicine papers on one of these failed acute heart failure therapies. So we don't have really the time to go through all of these individually, why they failed, but I do want to talk about some of the things we're commonly using in clinical practice and give you my thoughts on those. So continuous diuretic infusion. So this is supposed to work mostly by avoiding post-diuretic sodium reabsorption. So here's the concept here. So these are 6-hour urine collections, and you take somebody, you give them a loop diuretic, they get this huge increase in sodium output, but after 6 hours or so, the diuretic wears off, and they immediately go into this sodium retaining phase where the kidney's holding on to as much sodium as it possibly can. And it turns out in a normal person or a hypertensive patient or whatever, these two areas are the same. And so, this is why you can't use once a day Lasix as an antihypertensive, because they end up with a neutral sodium balance and it doesn't really move the needle on blood pressure. The other thing that's, I think, a little less appreciated is infusion wastes less diuretic. So, when you give a bolus, you get these real high peak plasma levels. And so you spend a lot of time at the top end of the dose response curve here or even saturated. So you're kind of wasting a lot of milligrams of loop diuretic. And so certainly if you're comparing an infusion versus a bolus, between those two factors, it should be gloriously more effective to use a diuretic infusion. So the dose trial is probably our best trial on this. The dose trial looked high dose versus low dose and infusion versus bolus in the 2x2 study. And it really couldn't be more negative, 4.24 versus 4.25. All the secondary endpoints were equivalent. Interestingly, in one of the post-hoc analyses, patients with the highest baseline diuretic requirement, so those with diuretic resistance, actually did significantly worse with continuous infusion. And really, the dose trial is not the only trial to show this. So people just keep studying continuous infusion because on paper it works so well that it's been studied a lot. And it's pretty reproducibly unimpressive results when it comes to diuretic infusion. So why doesn't it work? So first of all, is this post-diuretic sodium reabsorption thing even real in heart failure? And so this is euvolemic healthy subjects on a low sodium diet where it clearly matters. But when we've looked at this in the setting of acute heart failure, we don't see any renal compensation whatsoever. Actually, we see the exact opposite in acute heart failure, where the more you pee when you get the diuretic, the more you pee when the diuretic wears off. So it's really the global sodium avidity. And this is why, in America, most patients come in, they get 40 once a day of Lasix, and they still lose some weight, right? Which on paper shouldn't happen. But this is why, if you're not that sick, you're already natriuresing spontaneously, and there's no renal compensation. So the more you pee on the diuretic, the more you pee off the diuretic. The other thing is, at least in animals, we know if you put a rat on a Lasix drip, it has this massive distal hypertrophy of the renal tubules that allow them to defeat the diuretic, which probably doesn't happen with intermittent dosing. And lastly, we don't have a lot of outcomes data with continuous infusion, but at least in the dose trial, which was super underpowered to look at clinical outcomes, but wasn't going in the right direction. And there is some stuff published with longer duration of follow-up and longer exposure to the diuretic drip. We actually see significant separation of the curves where continuous infusion does significantly worse. So bottom line, trial evidence does not support meaningful superiority for routine use of infusion over bolus. On a milligram per milligram basis, infusion may actually be less effective than bolus in diuretic resistant patients. And this is probably because you don't get drug levels over the renal threshold. You really need that bolus spike in drug levels to get them over the renal threshold. May worsen structural modeling of the distal tubule and worsen diuretic resistance, which they'll leave the hospital with. And theoretically, that may be why some have observed worse death and rehospitalization with diuretic infusion. So how about adjuvant thiazide? So unlike infusion, which people just keep studying, there's actually never been a published placebo-controlled trial of thiazides. I think this is just because everyone knows they work and no one wants to waste their time doing a study they already know the answer to. There has been some safety concerns with thiazides. So we see worsening renal function, hyponatremia, severe hypokalemia, and even signals for death and rehospitalization. So some of this is confounding by indication. So the sickest people receive thiazides. Sick people also tend to die. So maybe that's the cause. So we actually set out to prove this. So we assembled this 20,000 patient data set at Yale, and we were going to show that you could adjust away the risk of mortality associated with metolazone. So, here's high dose furosemide. So univariate high dose furosemide is associated with worse outcomes. But as soon as you really adjust for how sick the patient is, there's no association whatsoever. It's all just confounded by indication. High dose Lasix is only bad for you because you were sick to have to get it. But we can't do that with metolazone. No matter how much you adjust how sick the patients are with metolazone, they seem to do significantly worse. So there is a trial that's been completed, a randomized controlled trial of thiazides. It has recently been presented in abstract form. It's not published yet. But basically, hydrochlorothiazide versus placebo, most people got 25 of hydrochlorothiazide, which is equivalent to 2.5 metolazone. And basically, what they found, as you would expect, you add a thiazide, you get about double the amount of weight loss with the thiazide intervention. They did a pretty good job of protocol mandating a similar dose of loop diuretic, so that was only slightly lower in the hydrochlorothiazide side. They got a ton more of these presumably small bumps in creatinine, almost 50% had at least a 0.3 bump. And, interestingly, and maybe consistent with the observational data, way too small of a study to really comment with just a couple hundred patients comment on hard outcomes. But unfortunately, the 30-day outcomes trended in the wrong direction with more mortality and more rehospitalizations at 30 days. In the hydrochlorothiazide group. So, too small for anything definitive, but certainly not encouraging that we should be routinely adding a thiazide early in these patients. So some practical tips for the use of thiazide. So most of us use metolazone in the US. It probably doesn't matter at all. They're probably all equivalent. What's a little appreciated here is oral metolazone, depending on the preparation, is really slowly absorbed. So no one knows where this came from, but this whole notion of give it 30 minutes prior to the IV diuretic is really nonsense. You really should be giving it a few hours beforehand. It also has a long half-life, so if you give it early, it's definitely still going to be there, even if it were to be rapidly absorbed. But the other thing is it can take several doses to see a full effect because it has to accumulate. So when I really want people to pee, I'll actually give a loading dose of metolazone. So Diuretic is our IV formulation. This has a really pretty short half-life and peaks immediately. So similarly, makes no sense to give 30 minutes prior to the loop. You should be giving it simultaneously with the loop diuretic. So can we do better than these less than highly effective and safe therapies? So we showed you before all these things that didn't work. I would submit there's some common factors here. So all of these are distally acting and really don't address the fundamental issue. And in my mind, the fundamental issue here is despite the patient being full of salt and water, the kidney is perceiving and acting on this information of a salt deficient state. So the kidney thinks there's dehydration, right? And so it turns out the kidney is really good at defending intravascular volume if it wants to. So this is some of Wayne Miller's data. People admitted to the Mayo Clinic, days of high dose IV diuretics, lose lots of extravascular fluid. But the black bar here is admission blood volume. The gray bar is discharge blood volume. And as you can see, like more than half really don't have any change in blood volume at all, despite these people being congested. And this is not pathophysiology specific to heart failure. The kidney is really designed to do this. So this is one of Chris Wilcox's old study where took normal subjects and gave them various different, even combination diuretics with a decent dose of BID Lasix and spironolactone. And when you look at the plasma volume, no different even with 2 diuretics compared to placebo. Again, the kidney is designed to do this. So this is what a lot of our current therapies like metolazone, et cetera, are doing. We're twisting the arm and the kidney's fighting back. And I would submit that a lot of the novel therapies that failed were like this little boy throwing a rock at a tank. We really wouldn't expect them to work. So teleologically, human is basically a bag of salt and water, at least kind of the perspective of a cardio-renal guy like me, that's how I look at it. And so our ability to exist outside the ocean depended on millions of years of evolution, developing the ability to keep exactly the right amount of salt and water in this bag. Like really pretty small aberrations in the amount, either the content, the quantity or quality of fluid and salt can cause some big physiologic problems. So given that human life cannot exist if the system doesn't accomplish the above, the complexity and redundancy is really profound. And honestly, we don't know how it works very well, but it is clear that it's very complex. So this is kind of how I synthesize why all these drugs failed. Someone's in their lab experimenting on mice and they say, oh, wow, natriuretic peptides, they do all this great stuff for the kidney. So let's synthesize natriuretic peptides. We'll give them to people with acute decompensated heart failure. It's going to be fantastic. Oh, no, it didn't work. All right, well, adenosine is important in TGF and all kinds of renal stuff. So we're going to block TGF. It's going to be great. We're going to see more diuresis. Whoops, didn't work. All right, well, vasopressin. Vasopressin does all sorts of bad things in the kidney. Let's develop a vasopressin antagonist. It's going to be great. Whoops, it didn't work. And as we watched each one of those fail, it was like really frustrating and surprising. It was like we didn't make sense. We know these things are bad for kidney function and volume regulation. But when you put them up on the slide at the same time and you say, hey, I'm just going to augment or block one of these, well, it's intuitive that these other pathways are just going to compensate, right? And like these are the 10 things I thought of when I was making this slide. The reality is there's this unbelievable complexity and redundancy here. So augmenting or blocking one of these mediators of sodium avidity, of course, is going to do nothing. And that's pretty much what we observed over the course of this experiment here. So I would submit that we need to get smarter, quench the sodium avidity signal upstream. So instead of doing this, we need to be doing this. So, the kidney literally filters a pound of salt a day. That's a lot of salt. With relatively small changes in how much it reabsorbs, we can get as much fluid and water out of the kidney as we want, but it has to want to do it. So rather than the stick, we really need to be using the carrot. So the kidney thinks there's not enough salt. Why don't we just give it more salt? So that sounds like a stupid thing to say, but let me walk you through some of the data on this. So this is a great study from John Burnett's lab. So he did a standard rapid pacing canine heart failure model, 3 different sodium levels. And if you scale this up, these are 20 kilogram dogs. So for a 70 kilogram human, this is like 20 grams of sodium a day in high salt. So on paper, these high salt dogs should have done absolutely terrible, right? 20 grams of salt a day. Wow, they should be doing terrible. So the first thing I want to point out, we also often forget this as cardiologists. If you eat a lot of salt, that means you pee a lot of salt. You never retain all of it. And so basically the kidney's being bathed in tons of sodium chloride. So, and of course, that's exactly what they saw. The urine sodium excretion was way higher in the dogs that were eating more salt. So neurohormones, well, PRA, aldosterone were dramatically suppressed. Again, not surprising. We know bathing the kidney in salt is going to suppress neurohormones, and that's exactly what it did. There was no difference in filling pressures or invasive hemodynamics, but I think the most persuasive is this clinical heart failure score was the best in the high salt animals. So this score was like, how far could the dog walk before it had to take a rest? Did it get ascites? Did it eat all its food? These are really more congestive symptoms, and they were better in the high salt animals. So very paradoxical to our traditional thinking on salt, right? So does this apply to humans? There's a growing literature to say, you know, maybe it does. So this is one of my favorite studies. It was a study done by some nutritionists that were going to prove that low salt is going to be super good for acute heart failure. So intervention was 0.8 grams a day compared to a standard 3 to 5 gram day sodium diet in the control group. They didn't mess with diuretic dosing, and they ended up about the same. If anything, it was a smidge lower in the high salt group. So again, by traditional wisdom, the high salt group should have lost way less weight. What do we see? Trend towards more weight loss. Actually, some of the secondary endpoints were actually significantly better, like their congestion score at 30 days, trend towards less rehospitalization. Probably a lot of you have seen the data on hypertonic saline. There's a bunch of papers at this point. Basically, you give hypertonic saline with the diuretic, you get more diuresis with less bump in creatinine. We published our experience with hypertonic saline not too long ago. About 58 different times it's been used. The protocol we use is 150 mils of 3% hypertonic saline given twice a day with high dose diuretics. Basically, as what we see, people's sodium and chloride are going down before they get hypertonic saline. You give sodium chloride, no surprise, the sodium and chloride in the blood goes up. But what was cool is we saw creatinine was rising before the hypertonic saline and improved afterwards. And importantly, the urine output and weight loss, also both of those significantly improved after hypertonic saline. So the question is can we disassociate this double-edged sword of salts, right? So clearly, some people do worse with high salt intake. Sodium is what's driving the volume overload. There's no debate on that. Sodium is bad, right? But from what we understand, chloride is actually the way the kidney sees salt. So we've known for decades that things like renin secretion and tubular glomerular feedback were actually driven by chloride rather than sodium. And over the last 20 years or so, basic scientists have figured out the actual molecular sensor for salt. So it appears to be this Wink-SPAC pathway where basically intracellular chloride, when it goes down, this Wink protein will autophosphorylate effectors like SPAC, OSR1, there's a bunch of them. And then basically every sodium retaining mechanism in the kidney seems to be regulated by this. So things like NCC, which thiazides block, and KCC2, which loop diuretics block, you name it. So low intracellular chloride triggers increased sodium reabsorption by the kidney. So we've been looking at this for the last several years. And the physiology or the observed outcome seems to follow the proposed physiology. So if you have low chloride, your diuretic response is low. If you have low sodium but normal chloride, doesn't matter, your diuretic response is normal. Same thing is actually true of mortality. If you have low sodium but normal chloride, you do just fine. Normal sodium but low chloride, those guys do very poorly. So we've been interested in this. So we said, what happens if we give people chloride without the salt? So there's no volume overload since there's no sodium, but possibly we get the same quenching of sodium avidity that salt gives us. So we published a pilot study on this several years ago, 115 millimoles a day of lysine chloride for 3 days. And so this is what we found. Not too surprising. You give chloride, the chloride levels go up in the blood. But what was surprising is we saw hemoconcentration in the majority of patients, and we saw about a 25% reduction in NT-proBNP. Again, with just 3 days in what we thought were otherwise euvolemic patients. But probably the most interesting thing we found is that levels of renal sodium transporters actually improved. And again, this kind of goes with the Wnt kinase pathophysiology, but normally if you do something to a human to remove salt and water from them, the body will upregulate these sodium retaining pathways. But we saw the opposite, where things like NCC and pendrin's like a salvage pathway the kidney uses, were actually significantly suppressed by just 3 days of sodium chloride treatment. So we're currently doing some studies to really chase this down the rabbit hole, but one of the questions is, can chloride be our cardiorenal carrot? Time will tell. So if you take home points, renal dysfunction and diuretic resistance are common in heart failure. Identify high-risk patients. Low output is not the predominant mechanism for either of these. As a result, really inotropes should be used for cardiac rather than renal indications. Achievement of euvolemia appears to be prognostically very important. This is even when it occurs at the expense of an inadvertent mild to moderate worsening of creatinine. When you encounter diuretic resistance, titrate the loop diuretic aggressively, add a thiazide if that doesn't work. And I would say this works in 95% of patients. 5% it doesn't work. These guys are super sick. We really don't have any evidence base to say how to treat them. And at this point, your guess is as good as mine what to do. And it's really trial and error. Things like renal doping, hypertonic saline, ultrafiltration. The reality is some of these kind of negative therapies that we say have been proven not to work. They've been proven not to work in the 95%, but we really have never studied them in the 5%. So we just don't know if they do work or they don't work. And lastly, in the sea of negative cardiorenal therapies really indicates we do need a paradigm shift in our approach. And I would submit that we need to really invest in understanding and targeting the signal that's more proximally and figure out how to attack it there. So I'll leave you with the diuretic resistance algorithm that I use here at Yale. So first, we maximize the loop diuretic dose. We go up to 12.5 of Bumex or 500 of Lasix. That's the highest our pumps will go. So that's kind of where we stop there. I used to always use Bumex when I was doing this. And the national shortages of Bumex have kind of challenged my praxis with that. So at least in animal studies, bumetanide is much less ototoxic than Lasix, somewhere between 8 and 10-fold less ototoxic. So on paper, it's better to use Bumex at really high dose. But the reality is we have a pretty good experience with this right now. We've even been doing some direct ototoxicity audiometry measurements. And the reality is in the absence of concomitant other ototoxins, these really are not ototoxic doses of diuretics. You can use them pretty safely. So SGLT2 inhibitor is next, if not at the same initial step up here. Next thing we do is add thiazide in pretty high dose. Next is things like spironolactone, acetazolamide. Even if you're on high dose spironolactone, sometimes you will respond to a Miloride due to these kind of direct proteolytic non-MRA based activation of ENaC. Renal dose dopamine is the next stop for me. Then hypertonic saline or just regular saline. And at that point, like in my experience, almost everybody that's gonna pee will pee by this. And at that point, I'm having a conversation, ultrafiltration versus hospice. And usually when you go down this road after already doing all this, these people are kind of destined to end up on dialysis if you do ultrafiltrate them. So I will stop there and would be happy to answer any questions.
Wow, that was amazing.
Unbelievable.
Thank you. Unbelievable, especially the last slide, which I'm sure raised some eyebrows in the room. So we're joined by our nephrology colleagues as well. Kate, what do you counsel your patients in clinic? Ambulatory heart failure, relatively well decongested. What do you tell them about their sodium limits? Dietary.
Unfortunately, I don't have an outpatient clinic anymore, so I don't have to do that. But it's really tricky, right? Because the only thing that I know with impunity is nobody knows the answer to that question. And it probably is a different amount of sodium for each patient, and it probably is a different amount of sodium for each patient at different times in their journey. I'm pretty sure it's not 20 grams a day, and I'm 100% sure it's not, 500 milligrams a day, but I don't think it's 2 grams. Is it 4 grams? I really don't know. And I think that's a major unmet need that we need to figure out, because this has potentially big implications, not just for quality of life. I mean, people hate being on a low sodium diet, but it's, there's a lot of evidence out there, observational, to say we may actually be harming people with too strict of a sodium intake. So it's unfortunately a very hard thing to study. But I really think the NIH and other funders need to invest to let us understand that better.
Agreed. I'll open it up to questions from the floor.
I have a question. First of all, Jeff, thank you so much for joining us. That was incredible. I have to say, puts to question everything we've ever been taught, and probably a lot of what we do, which is what, the kind of stuff we need to hear. Can you comment about the transition from once somebody's decongested back to what they need to be before they go home? How do we decide if, once we're done with IV diuretics, what we should do with pills? This is a big struggle for all of us every day, and honestly don't know what to do. Yeah,
well, join the club. I don't think anybody knows what to do here. So we've actually been really interested in this question lately, and we have a paper that's circulating right now. Hopefully be approved soon, or accepted soon. But the reality is, if you think about it, guidelines and most of our practice is you convert people to oral diuretics, watch them for a day or two, make sure it works, and then you send them home. And the reality is that actually doesn't make any sense whatsoever. So first of all, they're in the hospital on 2 gram sodium diet, and they ain't going to be on 2 gram sodium diet when they get home. So the diuretic response is entirely dependent on how much sodium they eat. So we already have something that physiologically doesn't make sense. Then you superimpose on that the fact that they just got, sledgehammers worth of IV diuretics for the last several days. So all their renal physiology is out of whack because they've just had this big equilibrium challenge. Their body fluid spaces are equilibrating, their creatinine's often bumped. So physiologically, they're in no position to assess the diuretic response that's going to happen as an outpatient. And then lastly, we all know with fluid in and out and daily weights, we can barely tell if somebody's losing 2 or 3 liters a day. So to try to give ourselves the illusion that we can discern if somebody's actually in a neutral sodium and fluid balance with that data doesn't make any sense. So we've measured a lot of these parameters, and just as you'd expect, the diuretic response at the time of transition to oral has almost no relationship to the diuretic response 30 days later, and the whole thing sort of falls apart. So how to do it properly, I don't know. I know what we're doing probably doesn't matter, and we others have shown that it's about 50-50 at this point in a lot of US institutions, whether people get the oral diuretic transition, and there's no different in outcomes in readmissions, whether they do and don't get it. So we need to do a randomized control trial to figure out whether we can just skip that and send people home with a dose we pull out of our ear, which is probably just as good. And we're developing some tools that might be able to help us better understand diuretic response as an outpatient. But so all I know now is we don't know, but hopefully over the next several years we'll have something to offer.
Sounds good. So we have a question in the chat from our chief fellow. He's asking, what do you think the role of acetazolamide is going to look like in the future, given the recent presentation of ADVOR at ESC?
Yeah, so what are U.S. physicians going to do? I don't know. So it has historically had basically no use in my practice, and it will continue to have no use. So there's a few reasons for this. So first of all the data we have as far as adding acetazolamide to people that are diuretic resistant as kind of or a second line or whatever, even in normal subjects, there's no synergy whatsoever. If at best they're additive, but in actually some of the early studies, even in some of Wilford's early studies, they're sub-additive. So you actually don't get much more diuresis with acetazolamide. And that's kind of what ADVOR showed us, right? They got a half a liter more diuresis with adding 2 diuretics compared to just using 1. In addition to the fact that the diuretic the diuretic doses of people coming in were restricted to only people on relatively low dose diuretics. So we don't know if they're actually diuretic resistant. But, why not just use more loop diuretic? Why add a second IV diuretic when you can just use a few pennies more Lasix? Because we have data from the dose trial, et cetera, that actually shows greater weight loss. The third thing is that, so you got a half a liter more urine output, but death and rehospitalization actually trended in the wrong direction in Advor. So if they got just a little bit more diuresis, but rehospitalization was at least trending in the right direction, I would at least be more agnostic to this notion that acetazolamide was maybe had something magic. But the reality is the things we really care about actually trended in the wrong direction. So certainly nothing compelling there. But I think the most important thing to me is, as I showed in my diuretic resistant algorithm, SGLT2, it's usually like the first day I'm on service, I come in, everybody gets started on SGLT2 inhibitor that day. Like, who should not be on an SGLT2 inhibitor that's admitted with heart failure? It's only gravy, right? SGLT2 inhibition was excluded from Advor. And in addition to the fact that means we don't know what will happen when you combine the two. So from what we understand in animals, and we have some unpublished human data that supports that this is true in animals, the entirety of the natriuretic effect of SGLT2 inhibitors is actually mediated through downregulation of NHE3. So SGLT2 regulates NHE3 in the kidney. Acetazolamide works by blocking sodium transport through basically CO2 recycling through NHE3. So on paper, from what we know about SGLT2s, at the best, we're going to see a much attenuated effect of acetazolamide in people on SGLT2 inhibitor, and there may be no effect for all we know. So the reality is use an SGLT2 inhibitor because that's actually good for people, makes them stay out of the hospital, feel better, live longer, et cetera. And we just don't have any of that data with acetazolamide.
Great. Thank you very much for that. And can you speak a little bit more to your nurse-driven diuretic dosing protocol? That is really interesting to me. How easy was that to set up? How smoothly does it work?
Oh, so now it works pretty smoothly. Like we've had it for a few years, and you order it and the nurses do it seamlessly. It was a lot of work to set up. Every hospital that's set it up so far, and there's probably 5 of them that we've worked with. I don't know who's done it independently of us. There's a lot of Epic integration, a huge amount of nursing training. So it's a pretty big lift to actually get it up and running. I mean, once it's up and running, it's really nice, but it is not for the faint of heart trying to get it up and running.
Yeah, it just seems pretty intuitive, actually. Food for thought.
It's interesting though how I think especially as heart failure physicians, it's kind of just like, oh, we know what to do with the diuretics, and it's used less than you think it would be, particularly it's like the more you know, the less likely you are to use the diuretic pathway. But yeah.
Fantastic. Don't know if there are any other burning questions. I'll say that we do have our nephrology colleagues in the room. We're going to start ordering furosemide 500 milligrams TID and reach out for consults. But all jokes aside, Jeff, that was truly, truly fantastic. Thanks for the talk. Thanks for kind of bringing us up to speed on the last 20 years. And thanks for opening our eyes to the new opportunities we have, hopefully, for this group of patients. That's been really helpful. And we may reach out to you offline to kind of talk some more about this nurse protocol, because I think it's really, really, really interesting.
Be delighted. Thanks so much for having me. I enjoyed it. Take care.
Thank you. Thank you very much. Bye-bye.